Well, thank you for coming, everyone. I'm very pleased to be invited by the Academy to undertake a head talk, which is sort of like a TED talk. I'm glad there's not that many people here because then I can tell more jokes and be more goofy, which is my usual style. But I was asked to start, or the head talk format is to start with an anecdote, so I'll start with an anecdote. A couple of years ago, in my office, I had a patient, a young man who I was seeing for the first time. He came in with his mother, and he had intractable nocturnal convulsions. He tried many medications. He wasn't taking any medicine at the time I saw him. He was new to me, but not new to the practice. He said he didn't like taking anti-seizure medicines because he didn't feel like himself. He felt side effects, and he continued to have seizures. He had a abnormal EEG, which showed left temporal spikes in the past. The recent one that I saw from our offices was normal. So I advised him to start a new medicine, one of the broad spectrum drugs with good side effect profile available generically. And he refused to take a drug. He documented it. I documented that, and then I asked him, if he would consider going to see maybe a cardiologist for an evaluation of possibly prolonged QT. It just raised my, raised the idea in my head because of his lack of reaction to the drugs, the normal EEG, 1 out of 2 at least, the nocturnal seizures. So he left the office, and then about 10 days later, I got a phone call that he was dead. He died in his sleep. The mom called me, and she was very upset and angry, and she said, did you know about this thing called SUDEP? And, and I said, yes, and she goes, well, why didn't you tell me about it? And, so after that, I felt really bad. But I didn't feel that bad about not telling her about it for some reason, but I felt really bad about not pushing him to take the medication. So harder. So that was really hard. But I think SUDEP is one of those entities that dare not speak its name, right? And why is that? I mean, doctors don't like to talk about SUDEP because we don't know what to say. There's not a good condensed body of literature. We don't like to talk about things that we don't know how to fix, and there's a perception of SUDEP that it's just random. It's like that story, Shirley Jackson's The Lottery. It just happens sometimes, and so what are you going to do? Should I really tell patients? Do they really want to know about it? This is the first time I saw this gentleman. So actually, there's literature that shows, yes, people do want to know about SUDEP, and that if you tell them, or if they know more about SUDEP, they have less anxiety about it, less worry about it. And around that time, I was asked by the American Epilepsy Society. Jeff Buchalter was spearheading the effort on behalf of their task force, Partners Against Mortality and Epilepsy, to write a guideline on SUDEP. So there will be a guideline published that will tell us the incidence of SUDEP in different populations from Class 1 papers, very highly vetted papers. It will tell us about risk factors, so we can stratify the risk of the patient in front of us. And we'll have a narrative put forth in the guideline to really guide us about what to say. So it's not that we won't have an excuse anymore not to say something, but we will be empowered to say highly vetted evidence-based information. So I really think that this will help to save lives. So I want to talk a little bit about the guidelines now. They have been created by the Academy since the early 90s. They were initially consensus-based, kind of documents. They were actually really nice, beautiful documents that helped us in management decisions. But around the mid-90s, a more scientific approach was adopted to look at the clinical evidence and vet it as to its quality according to bias. For example, a randomized double-blind controlled study is a relatively unbiased study compared to an open trial, right? So that would be considered higher level of evidence. So what does that mean? So for us in the guidelines committee, it means that we're closer to the truth, closer to, as getting a little bit closer to the reality, to the truth of what we can really tell people about managing their patients. So the other things that can affect the quality of the evidence are how many patients completed the trial. If all the patients who had side effects dropped out and the report is on all the patients who did great because they felt good and they took the drug, then it's, then that's biased. If the study population isn't really representative of your patients, if it's too narrow, for example, study isn't generalizable. So that would also contribute to the inability to take that study and really generalize it and use that information to guide your therapy. So the AAN guidelines are actually amongst the highest respected guideline methodology in the world. They've gotten awards, I guess, and there's a lot of effort on the part of the academy to support the guidelines. They give us 4 meetings a year. Sometimes they're in Minneapolis, which is, I think, a sort of exotic locale because it is the #1 bike-friendly city in the US. And they support 4 methodologists, not full-time but part-time, very highly skilled, highly selected group of people who work strictly on methodology and help to guide us as we navigate through the guidelines. So around that time then in the 90s, I think I can have, well, I'm getting close to my next slide. We were making guidelines on therapy, and we would make recommendations like, you should give this drug, or you must consider giving this drug for this condition, or you could possibly not consider giving this drug, or it might probably be helpful if you gave this drug. So all these statements came out, and they were as best we could do, but we got a criticism for how they were not nuanced and slightly obtuse. That was a good criticism, and I think from our point of view, we also felt that. We didn't have a methodology to incorporate things like side effects or idiosyncratic effects. How do you factor that in to the recommendation? We're struggling with that. And then around in 2011, we were really helped out by the guideline development process that was put forth by the Institute of Medicine. So they really, we were moving in this direction, but we were able to get a lot of guidance for how to really step up the guideline process. They were more strict in the conflict of interest. So now, when we develop guidelines, anybody who looks at the evidence to grade it has no conflict of interest. When the recommendations are formed, we need some content experts who are often conflicted, right? So half of the people who develop the recommendations, who are really familiar with on the ground how to use these interventions, they may have some conflicts, but only 50%. There's a lot more transparency. There's 3 public comment periods. I think for the nerdy people in the committee, what we have mostly appreciated has been the grade process. So that is when you have all these papers on an outcome, and they don't agree with each other. Like, what do you do when there's a class 1 paper that has a really small number of patients that shows one thing? You have a class 2 paper, right, not considered to be as good, let's say, lots of patients, shows something else. How do you reconcile those papers? We kind of did it by just talking through it, but now we have this process, the grade process, which helps us to really synthesize that evidence in a systematic way and come up with a strength of that conclusion. And then when we develop the recommendations now, they aren't as obtuse. They have a method to take in account risks versus benefit, which on that basis you can upgrade the evidence, or maybe you want to downgrade the evidence and make the recommendation not as robust because patients don't like it. patients can't afford it. It's not available. It's really a minor thing after all. So I think that we've come a really long ways to making our guidelines a lot more digestible and useful. And we worked really hard at it, and it's been a really great process. We still get criticized, though. So this is what I'm going to go into now a little bit. So a very enterprising medical investigative journalist, I just want to say that because I think it's a great title for a job. She put forth this critique of the Alteplase guideline, saying that everybody who wrote it was conflicted, basically. So how do you respond to that? So, well, we followed our process, so, there's not really a lot of response, except to say that we followed the Institute of Medicine process. However, we did develop a new conflict of interest form, and this is not that, because I really just wanted to demonstrate how we're looking at conflict of interest. We developed the 6 degrees of separation conflict of interest idea, which is that conflict of interest is not easy, and I think the people in the guidelines committee really think that I'm not engaged in it. It's too hard for me. It's too difficult. This conflict of interest is all about money. So if you're a speaker or consultant for a drug company and you do your job and you take the money home, that's pretty easy, right? That's conflict. If you're a site PI for an NIH-sponsored trial, you don't take the money home. If you're a site PI for an industry trial, for the, a drug of interest that the guidelines being written about, is that conflict? How there's a gradation and we have to make a judgment. It's not easy. So one real conflict we had was that the guideline was about this specific drug, and one of our methodologists was paid to go to a meeting, or no, she wasn't paid. The travel was paid for her to go to a meeting about a drug. It wasn't the drug that was of interest for the guideline, but the company made that drug. So it's like, I'm not sure where we draw the line, but conflict of interest is not easy. It's a difficult thing. It seems straightforward. What about this difficulty that we've come across? People just disagree with the guidelines. There was a big editorial just written in the Annals. They just disagreed with what we found. And, I went through our process with you. This is the rebuttal. My own view is that blah, blah, blah. So we synthesize the evidence. We're up against this person's own view. So how do we respond to that? We basically double check what we do and otherwise let it stand. We follow our process. And by the way, following our process is a legal requirement of the academy. The lawyers follow very closely what we do to make sure we're compliant. Now, the last conflict I want to mention that we come across is when we send the papers to Neurology. They're peer-reviewed. So one of the tenets of evidence-based medicine is that you look at a paper and you believe it, that you have to evaluate this as real evidence. Unless you have evidence that it's fraudulent in some way. So there's a paper that we sent to Neurology that will never see the light of day because one of the reviewers thought that based on the geographic origin of this paper that it couldn't possibly be valid. And it's almost like it's just a matter of faith. You can't convince somebody to believe in the results. They don't have any evidence not to, but we just could not come to terms with it. So I'm just putting forth some of the challenges that we have working through our process, and we get attacked sometimes. But it's okay because we've slowly worked, I think, towards the truth. And we, by the way, vet our guidelines every 3 years. So if we got it wrong or we're off base and there's new evidence, we'll move closer towards the truth next time. And I just want to do one other thing. Let's see. Okay, I want to get back to the desktop here. So one other side benefit of working in the guidelines is that you get to work with really kind of nerdy people, and I'm going to make a comparison to NASA. So NASA, the space program, got us out to outer space, but there was a lot of spin-off technology that was very, very helpful to the world at large. So I became obsessed last year with the relationship between alpha, beta, effect size, and sample size as a teaching tool. And one of the methodologists in the academy was able to make this program for me. I'm going to show it to you. So look at the alpha and the beta. And you can put in different sample size here. Move it along. So isn't this is like the coolest teaching tool. So I'm really sorry, but this is like the most cool thing that's happened to me in the last month. And as a teaching tool, the residents and fellows love it. But it's one of the spin-off effects of the kind of navel-gazing and obsession that we have in our committee with finding the truth. So my last statements about the guidelines are, we do vet them every 3 years to see if they can be tweaked and improved and updated. If data comes out in the meantime that shows that our guidelines are not valid, we will take them down until we get a chance to revise them. This happened recently with treatments for migraine prophylaxis, where several of the alternative medicines were found to cause liver failure. So we didn't have time to redo it, so we had to take it down until we can fix that. So we try to be responsive. The other response I have sometimes to feeling a little bit critiqued sometimes by the world at large is that we do the guidelines pretty well. And we do it so you don't have to do it. You don't have to synthesize all the data and come up with the recommendations. And it's a hard process, so sometimes I feel like, when I'm in a feisty mood because I'm Irish after all, well, if you think you can do it better, you do it. But the guidelines process for the academy is very evolved. It's very sophisticated, and there's a lot of dedicated people. And regarding SUDEP, I think, we will get criticism, there will be challenges, but I believe that in the end, when people see the guidelines, it'll make them think more deeply about SUDEP, the risks, be able to see that, that patient in front of me basically had all the risk factors for SUDEP. But I didn't see that, and maybe me in the future and other scenarios for physicians in the future like that will have a little bit more understanding of the situation, and I believe that in that manner our guidelines will save lives. So that's the end. Thank you.